Next topic is cardiac evaluation in diabetic paradoxality. We may invite Laxmi and Sunetra.
Good evening, everyone. A big thank you to the organizers for having us here. It's so great to be a part of this meeting. So the topic for deliberation today is cardiac evaluation in diabetes before general anesthesia. So me and Dr. Sunetra were wondering, who is the best specialty to discuss this with us endocrinologists? Anybody? We'll ask the organizers. Saptarshi sir, anyone? I would say maybe a anesthesiologist. In fact, my husband is an anesthesiologist and he's here, but he did not volunteer to help us on stage, so anesthesia is out of the question.
So next who? Maybe a cardiologist. Do we have any cardiologists over here to help us out? Okay, thank you, sir. So maybe you will help us at least with the questions that come in the end. So both of us are endocrinologists, so we thought of a little hack that one of us will pose as a cardiologist for this session. And so, but the organizers have clearly mentioned to us that humor at the cost of other specialties is not going to be entertained. So we thought we will make fun of ourselves instead. But we do have a very important disclaimer. Please go through it carefully, otherwise our feathers will fall off.
Yes, disclaimer.
I hope everybody remembers the story of a crow posing as a peacock.
Okay, disclaimer is very important. I hope all of you have read this. So we have converted this duologue into a duel between two logies, a fake cardiologist here and a real endocrinologist. So Dr. Sunetra has graciously agreed to pose as a fake cardiology for the sake of this session. So we're good to go. So, hey cardiology, it's good to see you here. What are you doing at an endocrinology meeting though?
Yeah, just hanging out with my husband who is an endocrinologist.
Oh, okay, great. You know, SPEEDCON is now listed on the US Endocrine Worldwide calendar for the important endocrinology events worldwide. So, feeling honored to be here, huh? Okay, now that you're here, let's discuss some academics. What do you say?
Yeah, good idea. So what do we discuss about? What do endocrinologists and cardiologists have in common? Dr. Mohan?
I would beg to
what
differ.
What
sir.
about SGLT2 inhibitors?
No, not SGLT2 inhibitors. SGLT2 inhibitors belong to endocrinology. I think the organizers will agree with me. No discussion about that.
Okay, so this will start a debate. Now we should proceed, I think.
Okay, so we are not going to discuss about SGLT2 inhibitors. We are going to talk about some cases. So I'm very mad at you for cancelling cases left and right. All my patients I'm sending, you are asking for unnecessary investigations and not giving fitness. This patient of mine, 70-year-old male, diabetes since 30 years, on insulin, well controlled with an A1C of 6.6. Poor gentleman got diagnosed with colon cancer and he was posted for a laparoscopic right hemicolectomy. He had no hypertension, he had only mild non-proliferative diabetic retinopathy and no evidence of end organ involvement. His BP was normal, no postural fall, and systemic examination was normal, and still you asked for so many investigations.
So your patient did have a high pre-op cardiac risk.
What risk are you talking about? Don't go off into your Framingham risk calculators now.
Come on, Framingham is not the only cardiology risk calculators available. We have very well validated pre-op cardiac risk calculators as well. The most common and the easiest to use being the revised cardiac risk index calculator, which has 1 point each for ischemic heart disease, cerebrovascular disease, history of heart failure, diabetes on insulin, creat level more than is equals to 2, and if the patient is planned for a high-risk procedure. So your patient is on insulin for his diabetes and he is planned for a bowel surgery, which is a high-risk procedure. So he definitely qualifies for high risk.
So now that you mention about the risk indices, diabetes is one of the components of almost all the preoperative risk indices. So all the patients with diabetes automatically qualify to be high-risk patients?
Yes, and you must be knowing that the surgeries can also be classified according to their risk for post-op mess. So less than 1% is low risk. Your endocrinology is definitely a low risk branch. Even your most common surgery of thyroidectomy is a low risk surgery. So intermediate risk like head and neck surgeries or peripheral arterial angioplasties. And in the high risk group, yes, your adrenal resection is the only high risk emergency surgery, I guess, and all bowel surgeries, of course.
Now tell me in simple words, which of my diabetic patients will require an ECG, echo or stress testing, and who will require your favorite angiogram and angioplasty?
Okay, so we do have very specific indications for that. So as per the European Society of Cardiology, preoperative ECG is recommended for patients who have risk factors and are scheduled for an intermediate or high risk surgery, though it may be considered in those without risk factors or those undergoing low risk surgery. So along with diabetes, if they are having any other risk factor in the revised cardiac risk index that I mentioned, they do qualify for a pre-op ECG. Regarding pre-op echo, it may be considered in patients undergoing high risk surgery only. Before we go into stress testing, we need to assess the functional capacity of the patient, which can well be done by asking some simple questions like whether the patient can climb 2 flights of stairs or walk up a hill, which qualifies for 4 metabolic equivalents, which is the cutoff we use for poor functional capacity. So imaging stress testing is recommended before high risk surgery in patients who have more than 2 clinical risk factors along with a poor functional capacity.
Okay, so from this ECG, echo and stress testing, eventually we are going to go into coronary angiogram and revascularization. Sorry to disappoint you, but I came across this trial, the coronary artery revascularization prophylaxis trial, which had 510 patients with coronary artery disease scheduled for vascular surgery, and they were randomly assigned to coronary artery revascularization after surgery or no coronary artery revascularization. And what was interesting is that post-op MI within 30 days of these, both the groups were not different. Even long-term mortality at a median follow-up of 2.7 years were not different between the groups. So is there any use in doing all this testing and eventually going to coronary angiogram and angioplasty? Though there was a caveat with this study that patients with left main CAD and reduced LV ejection fraction were excluded from the trial. So what do you say?
Yes, there is a discrepancy between the two chief bodies regarding the need for prophylactic coronary revascularization before surgery. So the ACC-AHA recommends against, and the European Society of Cardiology, however, feels that prophylactic revascularization may be considered before high-risk surgery only if there is substantial evidence of stress-induced ischemia.
So what I have understood is that your coronary angiogram and angioplasty may or may not be beneficial, but what I know for sure is that medical management is definitely beneficial. Let me talk about the medical management that we as endocrinologists or physicians can do before sending you for high-five procedures. So beta blockers, if patient is already on beta blockers, continuing beta blockers definitely has a role in risk reduction. If the patient has diabetes plus other risk factors, we may consider initiation before high-risk surgeries. About statins, continue if patient is already on statins, but if patient is not on statins, should be initiated at least 2 weeks prior to vascular surgeries. In stable patients with heart failure plus LV systolic dysfunction, if patient is already on AC inhibitors, they should be continued. If they are not on AC inhibitors, should be initiated at least 1 week prior to surgery. But it should be remembered that if the indication of AC inhibitors is for hypertension only, they should be transiently discontinued a day prior to surgery and should be restarted once the patient is hemodynamically stable, because the peri-op use of AC inhibitors has been associated with significant hypotension. Among the calcium channel blockers, only diltiazem has been shown to play a role in risk reduction. They should be continued or introduced in patients not tolerating beta blockers for these very indications. Okay, let's talk about another patient of mine, 62-year-old woman, had a TIRADS 5 thyroid nodule, FNAC was suggestive of malignancy, and she was posted for a total thyroidectomy. She says, my patient had 15 years diabetes, well controlled on insulin. You had done an angiogram a few years back, it was showing non-critical ischemia of the LAD, and you had put her on aspirin. So should she continue aspirin before surgery?
Okay, so this is a very individualized decision based on the balance between the bleeding risk and the thrombotic risk of a particular patient. So if the bleeding risk is high, of course, we may need to discontinue. And of course, wherever surgery can have, bleeding during surgery can have catastrophic consequences, we need to discontinue, as in spinal, neurosurgical, or ophthalmic procedures.
Okay, let's talk about another patient of mine, 58-year-old male, diabetes since 5 years. Now I'm just going to stop saying well controlled because all these are my patients and they're all very well controlled. You had done a coronary angiogram and he had undergone an angioplasty 8 months back, awaiting surgery for left inferior parathyroid adenoma. And it's not an emergency because calcium is normal on my medical management.
Yes, as expected, endocrine surgeries are hardly any emergency, but at least tell me what stent did he undergo?
Does it really make a difference?
Yes, of course, a lot, because for patients who have undergone a bypass grafting, you should ideally delay any non-emergent surgery by 6 years. For those having bare metal stent, at least 4 weeks and ideally 3 months. For those with drug-eluting stent, at least 6 months and ideally 12 months. For those undergoing only balloon angioplasty, you may consider doing surgery after 2 weeks. But if this amount of delay is not possible for a particular patient, regarding the dual antiplatelet, the aspirin must be continued. The other antiplatelet should be discontinued at least 5 days prior if it is clopidogrel or ticagrelor, and for prasugrel at least 7 days prior to surgery. And all of these must be restarted immediately after surgery.
Okay, another patient, 70-year-old female, diabetes since 8 years, essential hypertension since 15 years, no established ASCVD. She was on a lot of antihypertensives, BP was still high, and ECG was showing all these high voltage complexes. She is planned for an elective cholecystectomy. So does she require, I think it's better to cancel this surgery, right?
So your high voltage complex basically fulfills the criteria for left ventricular hypertrophy due to hypertension. Thankfully, knowingly or unknowingly, you have checked for the creatinine levels, because I think you remember the stages and grades of hypertension. So for grade 1 and 2 hypertension, we need not really defer surgery. We should only screen for end organ dysfunction prior to surgery. The main aim is to avoid perioperative blood pressure and heart rate fluctuation. So if the patient is on beta blockers, the target resting heart rate is between 60 to 70. Systolic blood pressure must be more than 100. As you said, the ACE inhibitor ARB should be discontinued at least 24 hours before surgery, and any overt dyselectrolytemia due to the diuretics must be corrected.
Okay, so we'll go ahead with surgery for this patient then. Another patient, 64-year-old female, diabetes since 12 years, again no established ASCVD, but she's been having episodes of dyspnea on exertion. She's having pedal edema and JVP is also elevated. ECG is showing all these white complexes, not normal, definitely, awaiting modified radical mastectomy. So what is your say on this patient?
An echo?
Yeah, you had done this echo and it was showing really dilated chambers and EF was 25%.
Okay, so your patient is having an acute heart failure with reduced ejection fraction, which actually has a lot of perioperative implications, because the post-op mortality rates are actually higher for non-ischemic heart failure than for ischemic heart failure or coronary artery disease per se. Stable heart failure, even these patients have longer hospital stays and greater rates of readmission, all of which can be improved by optimizing the medical therapy. Just like your diabetes, heart failure is also a part of almost all the preoperative cardiac risk indices. Natriuretic peptides, ideally you should also measure to improve the risk stratification. Now regarding a newly diagnosed or acute heart failure, you should wait for 3 months before any non-emergency surgery, in which time you should initiate and titrate therapy. And your SGLT2 inhibitor is not the only drug that needs to be optimized. The other drugs like the AC inhibitor, ARB, the diuretics, if required, mineralocorticoid receptor antagonists, all of this must be optimized before the patient is put to surgery.
Okay, fine. Let's talk about this patient, 65-year-old male, diabetes since 22 years on tenligliptin, CKD stage 2. He is now presented with a non-healing infected neuropathic foot ulcer requiring amputation and is also receiving antibiotics, ciprofloxacin. I did an ECG and QTC was 500 milliseconds.
What I cannot believe, you actually calculated the corrected QT for this patient.
Of course not. I don't have the time for it. It was an automated report and really marked in red. Hard to ignore, really marked in red. So,
Okay, so I think your patient is having cardiac autonomic neuropathy. So your patients are all having excellent glycemic control, but some macro or microvascular complications. So for the symptomatic patients with cardiac autonomic neuropathy, say for somebody with postural hypotension, ideally you should do an ambulatory blood pressure monitoring and a 24-hour Holter to look for arrhythmias before you go for surgery. Even the asymptomatic patients, if not more sophisticated tests, at least 2 bedside tests, the heart rate variability with deep breathing, where you calculate the RR interval on expiration and inspiration and calculate the ratio, and the orthostatic test, during which you calculate the RR interval at 30 minutes and 15 minutes after standing, and both these ratios should be plotted on age-specific graphs to know if they're abnormal and if the patient qualifies for a cardiac autonomic neuropathy. So if he or she is having, the first thing you need to do is avoid QT prolonging drugs, your teneligliptin, and look at the antibiotic you have given, fluoroquinolone. Close monitoring of blood pressure and arrhythmias, of course, and please make aware your anesthesiologist husband. He may be having a difficulty during intubation if the patient is also having gastroparesis.
Yeah, he's smiling. I think he knows that. Okay, let's talk about our last patient, 47-year-old female, diabetes for 25 years, CKD5 on maintenance hemodialysis for 1 year, awaiting kidney transplantation, no established ASCVD, and ECG showing LVH. So any precautions from your side?
Okay, so for transplant patients, preoperative resting ECG, even those without known cardiovascular disease, and should be repeated annually as long as the patient is enlisted but not have been transplanted. But preoperative echo only once, it need not be repeated. Cardiac troponins act as an additional prognostic marker. Regarding the need for non-invasive stress testing or a pre-op coronary angiography, the Kidney Foundations recommends it for all patients with diabetes, but the ACC-AHA says it should be done only for those who are having 3 or more CAD risk factors.
Okay, now I have understood that in all my 8 patients, you have cancelled or asked for more investigations in 7 patients and said to go ahead with surgery with only 1 patient who had hypertension. Okay, let's wind this now. I have an emergency call.
What emergency? Blood glucose of 210.
I think we are taking this too far at laughing at ourselves, and Dr. Sunetra here has actually forgotten that she's a fake cardiologist. I think you need to come back to our boring non-emergency endocrinology world now. So just to summarize what we have discussed, if the patient has cardiovascular risk factors or CV disease and is scheduled for a non-cardiac surgery, assess the risk factors based on one of the risk indices mentioned. The revised cardiac risk index is the most commonly used, and if the patient has a perioperative MACE of more than or equal to 1%, optimize medical therapy to reduce his CV risk and then assess his METs. If his METs is more than 4, can go ahead with surgery, but if it is less than 4, first see if further testing and intervention will have any effect on the decision making of this patient. If it does, conduct non-invasive stress testing, and based on the findings of the non-invasive stress testing, proceed to surgery or consult cardiology for angiogram and possibly a revascularization. Thank you for your patient listening.
Thank you so much.
Well presented case series. Any question from the audience? Okay, all seems to be satisfied with your explanations.
And
Thank
also,
you.
don't forget there are 2 surgeons chairing the session. There are 2 surgeons sitting here chairing
Oh,
the
sorry,
session.
we did not get surgeons into this. I thought it was already very controversial.
So only the surgeon can understand the pain of cases getting cancelled.
Okay, yeah.
Noted,
Thanks for the
sir.
lovely banter too.
Thank you, sir.